Welcome to a Shot in the Arm podcast. I'm your host, Ben Plumley, and this is a podcast about innovation and equity in global health. Well, this is a follow-on episode from the one we did just prior to AIDS 2022 in Montreal at the end of July 2022, where we discussed the role of laboratory-based and point-of-care diagnostics in the management of infectious disease. It's something I've become a bit obsessed about, both domestically in the United States and globally, as part of sustainable prevention and treatment strategies, as well, crucially, as part of the pandemic's preparation and response. It's the Cinderella, if you like, of infectious disease management. Well, we're recording this episode at the end of Infectious Disease Week, and I'm hugely grateful to this episode's sponsor, Roche Diagnostics, and particularly for again giving me the chance to chat with two of its top physicians, Tamar, Tchelidze, and Ben LaBrot, both of whom, as you'll recall, have fascinating and hugely important careers in their response to infectious disease. So, let me welcome our guest. First up, Dr. Tamar Tchelidze. She's a disease partner at the Medical and Scientific Affairs at Roche Diagnostics, formerly Senior Policy Fellow at the UCB School of Public Health, and Health Counselor for the Ministry of Foreign Affairs in the country of Georgia. Tamar, welcome back.
Thank you, Ben. I'm thrilled to be here.
And we're also joined by the other Ben B., Dr. Benjamin LaBrot, Medical Affairs Leader for Infectious Disease at the Medical and Scientific Affairs at Roche Molecular. He's also a clinical professor at USC and, of course, founder and CEO of Floating Doctors, a non-profit medical mission that works with coastal relief groups to provide specific and needed clinical assistance. Ben, welcome back.
Thank you so much. Glad to be here.
So I guess my first question for you both is, what have you been doing since we last met? Tamar, I know you've had quite the summer. You were back in Georgia, I think. How was that?
Well, thank you, Ben, so much for this question. It's a painful, what the situation we're all in, the whole world, actually, not only Georgia, but of course, Georgia is affected also one of the most. And I will go answering this question from the healthcare perspective. So the situation have really significant impact, and I would think that it will be even worse in terms of the access and delivery, as we do have the massive number of people coming into Georgia, not only from Ukraine, but as well as from Russia. And I really care about and worry about the continuum of care, whether it's preventative, such as PrEP or other screening, or treatment for HIV patients or other diseases. I also fear that given this, situation in terms of the anxiety, the PrEP or any other preventative services will be least on the people's mind, because that's the situation we are in. So it's really tough at the moment to predict, and it really depends, how robust is the health systems in Georgia, and whether people can also afford to do to access the care and receive the care without driving them into poverty. So we are still in the middle of pandemic in Georgia, of course, and not really fully recovered. It did really have the damaging effects also, of course, like rest of the world, also in Georgia. So additionally, the winter is coming, right? We are in the fall now, and it's flu season. I don't know how ready we are in terms of the vaccination. How can we get the word out, or to everybody to come and do the vaccine, or do we have enough vaccine? But what I can tell, the hope is what is in my mind now, and we should really go above and beyond to ensure that all people, regardless of their status, whether they're Georgians or people coming inside, they access the healthcare at the time when they need it. And of course, the care also should be of the highest quality that we can provide, and it should be really equitable to everybody. So, and as the last point that I want to make is that I would think that many of the displaced individuals probably those again, I think I've mentioned this already, that's the least in their minds, and we need to make sure that they not forgetting, what treatment they were on, or what, they were receiving, they continue to do so.
I mean, it is. We're so focused on the pressure on health systems, on some of the countries in the European Union, Poland, Germany, the Czech and Slovak republics, particularly. We don't really think about, in the sort of Central Asian sphere. I can only imagine how much pressure this must be putting on the Georgian health system. And Ben, sorry, go ahead, Tamar.
No, I just agreed with you. So,
well, I think we'll probably come back to this as we talk about in more depth the impact on PrEP and treatment, HIV treatment. And Ben, what have you been up to this summer? If I recall, you took some time to be back with Floating Doctors.
So I managed to spend a bit of time with Floating Doctors, and I must say, still dealing with kind of the wreckage of the pandemic. The indigenous population we serve ended up suffering some pretty widespread starvation during the pandemic, and despite about 700,000 meal portions being handed out by my team down there, I mean, it was like a drop in the bucket. And the number of kids, with really like clinical malnutrition and stunting that are now on our active management list is 5 or 6 times what it was prior to the pandemic. I really believe that there may be an entire generation of shorter adults due to the stunting effect, the starvation and food insecurity that came with the pandemic. And a large number of chronic patients who would heart disease, diabetes, epilepsy, HIV, who were previously being covered by the Ministry of Health were lost to care during the pandemic and ended up on our list. So it's been a very large additional workload. That being said, in the midst of all this, some really positive developments. The Ministry of Health and the Panamanian Center for Disease Control has made the commitment to support us being able to bring PrEP into these kind of remote communities. And of course, with some of the new tools, long-acting injections, this is sort of practical, like for the first time ever. So we're really excited about this, as we've really seen HIV really skyrocket there over the last few years.
Isn't it funny? I mean, we're talking about different parts of the world, but food insecurity, pressures on health systems, it's all the same. I mean, one piece of good news from my side, which I'm so proud of, it's a country I've worked so extensively in over the years, is Zimbabwe, the first African country to approve long-acting PrEP. Kabele is approved in Zimbabwe. It's fantastic news. Well, anyway, there you are on the East Coast. Here am I on the West Coast. You've been at Infectious Disease Week. So to borrow a phrase my father uses from Shakespeare, what news from the Rialto? Tamar, what has been getting your attention?
To be honest, I would start this that if we really are serious about HIV epidemic, it's really critical that everyone who is sexually active know their HIV status. Everyone with HIV receive also high quality care and treatment. And that we really end the stigma around HIV and AIDS. And I know that your question was broad, and I'm specifically answering on HIV since this is how we started the conversation at the first time, but that's what it is on my mind. And while speaking on HIV, it really is about all of the infectious diseases, not all, but most that we are concerned about. And we see that we mentioned antimicrobial before we even started recording. Whether it's monkeypox or COVID. So that, what we learned, I will specifically talk about the HIV, is that we have many, many gaps, that we are not really as prepared as we would like to be, especially in identifying everyone infected or linking everyone to PrEP or respective services. And we do see clearly that in this era, we still have 35,000 new infections every year. We have to start really focusing on implementing educational programs for all types of stakeholders, not only for the healthcare providers. And in healthcare providers, we can also need to go deep down and see who are they? Who are the those providers that really talk to the people and patients. now that PrEP guidelines are also out, and we are absolutely thrilled to see, like we said, it's, during our first recording, that there is a lot to be done in educating primary care healthcare provider on new diagnostic algorithms. That for many, what we learned actually during this ID conference, as we also had the event we attended the event specifically, how this algorithm works, and a lot of questions, even from the ID physicians, because it looks like confusing for them. So we need to simplify, we need to educate, and the ID physicians should also get involved even more in terms of educating primary care physicians. Of course, we need to address gaps in the, what the testing cost and the coverage issues are. And we also need to absolutely make sure that the patient have access to the services and without having any issues whatsoever, whether that's cost or the transportation or that's just few of the things that came to my mind.
Ben, you had mentioned that this was the perfect conference to nerd out on. So what came up for you that caught your interest?
There's certainly a lot of really interesting new developments in treatment, certainly. We've got the 2-month cabotegravir, and it looks like there's a 6-month, kind of long-acting injection in the pipeline in phase 3 trials. There's a transdermal patch where the drug itself is formed into tiny spikes made of crystals on the other side of the patch. I mean, it's just, there's impregnated, like piperine rings. There's a lot of really interesting tools kind of coming out, that are going to be really handy. Aside from kind of a lot of the cool new stuff coming out, the other thing that I'm really hearing is this one overarching message of how our rhetoric really, our policies really have to match our rhetoric. As we hear a lot of, U equals U, we're going to, end the epidemic. When we have policies, that don't match that, it's really frustrating. And I could see that they're causing a lot of frustration for other ID docs that are there, like simple things, that just don't make sense, like to an ID doc, like Fulton County Jail in Georgia in 2018 discontinued its diagnostic screening for HIV for almost all inmates coming in. They could opt out, but otherwise they were doing a rapid test on everyone who came in. And a study found that, in 2013, when they were doing that, they found 74 more infections than in 2018, where this more random testing procedure came in. And this change in testing, was estimated to cause 8.5 additional HIV transmissions and almost $4 million in additional cost to the healthcare system. So a few dollars were saved on rapid tests, but some lives were destroyed and millions were lost. And as diagnostics is the gateway to care, I think we're really seeing the need to make our commitments really match our rhetoric. And while, of course, the part of me that finds that so dismaying, I will say that the attitude among the infectious disease docs here is really great. They're the number one burnout specialty right now. And still, the people that are here that we're hearing speak really speak with a lot of dedication. There was an ID doc from Kentucky I heard make a comment in an industry education night. He was saying, in relation to the new PrEP guidelines, that for his mostly Medicaid population, many of whom are elusive, he's a hero if he can get a viral load testing at all. And he said, in his view, the new testing guidelines are maybe medically optimal, but in his, are not very practical for his setting, even though they've just gotten a very large funding grant. It was like a drop in the bucket to achieve that. But I think he actually said, and if he's listening, I apologize for butchering what you said, but he said something like, it's totally impossible. Of course I'm going to do it anyway. I'm going to implement PrEP. I'm definitely doing it. And this is totally impossible, but hold my beer because I'm going to do this anyway.
Hold my beer, love it.
It was really great to see. If we see that kind of commitment, at all levels, from the top down to docs, like him, really at the tip of the spear for this kind of thing, I think we're really going to be able to make some progress. But we do have to close that gap between rhetoric and policy.
Well, closing the gap between rhetoric and policy, and you've both been very gracious and not asked me to comment about what is going on in the United Kingdom. But there was just at the moment, but there is one thing that I think, to both of your points, really shook all of us, and that was that the health secretary in the United Kingdom was trying to open up availability of antibiotics. And she was suggesting that, you could get them without prescription, and that, she even reported that, she was giving friends and family leftovers of her own pills. And, when we talk about antimicrobial resistance, right, I can see Ben putting his hand over his head.
Oh, God.
Just amazing. Speaks to the need for policy and practice to be so clearly linked in. I was in Puerto Rico last week for the US conference on AIDS, which was, I think, more of a community-based conference. But it really struck me that while a lot of the attention was on the excitement of long-acting and PrEP, there was really next to no conversation about the diagnostics infrastructure that's needed to support that. And I know that's really the key theme of this podcast, but I really think we've, as policymakers and advocates, need to do much more. And I guess this is the nice way of kicking into the conversation about diagnostic pathways as an entry point for prevention, care, and treatment in infectious disease, particularly HIV, but not only. And I just, to kick off, I just wonder, Tamar, maybe I could start with you. Why do you think we have such a hard time getting diagnostics to the top of the policy agenda?
So diagnostic is really most important, if you ask me. And we talked about this before. I'm really glad you asked this question. It's actually plays the crucial role in the prevention and treatment. It's like in the middle of the gateway, whether we link people to care or link people to treatment. I think awareness is one of the top of the things for the policymakers, that they need to realize that it's so important that we identify, first of all, people. If we are serious about the elimination of any of the diseases, and HIV is no different. So with the care continuum and testing, when you screen individual, you link them to care if they're positive, and then you link them to PrEP if they want to take PrEP, or you think that they should take PrEP. But the point is that that's the only way. It's the only way you can really keep the transmission down. And of course, very important, also equally important, I would say, that sustainability and consistency in approach. It's very necessary if we're serious about it. Until you, of course, reach the goal and even beyond. And we witnessed how aware everyone was about HIV a few decades ago, right? Because we were consistent with the messaging about how dangerous the virus was. And now HIV is under forgotten diseases list. And we need to, and policymakers need to really realize that. And we need to make every effort possible to put it under the rare diseases list. So we need to do it again with the messaging and education, and that involves all stakeholders, including the policymakers. And in we, again, I mean all of us, HCPs, the patients, the payers, the private sectors, the advocacy groups, the government. So that's all of our responsibility. And if we are right with the messaging, I would say that we will not be asking this, why it's not on the top of the list for the policymakers as well.
Ben, you mentioned new PrEP guidance coming out, and that there were discussions about that at ID Week, Infectious Disease Week. Where do diagnostics fit into that, do you think?
Well, I mean, as Tamar mentioned, it's really the gateway to care, not only to entry of care, but to maintaining people on care, to managing their care. So it's not like you get your test and then you don't need any more testing, right? So, and especially with more elusive patient populations, hardly reached populations. I really loved, that comment that you heard about the difference between hard to reach versus hardly reached. I think I'm going to start using that exclusively from now You know, if you're trying to save, as Fulton County Jail, a few pennies on tests like that, or even dollars, the result is ultimately usually a much greater economic impact. You talk about a couple of extra dollars for a test, you miss one new case, or you miss a case that causes one new transmission. There's another 300, 400,000 to manage that, on average, to manage that patient over their lifetime, sometimes much more. So I think it might just be that treatment is sort of sexy. Treatment, you've got someone on treatment. Diagnosis, you've just highlighted and confirmed a problem. So most people prefer to be able to say, here's the solution. And of course, diagnostics is the gateway to the solution. But I think it's sometimes dismaying. The more people you test, the more people you find. So it also causes the problem to appear bigger. Maybe that's a little discouraging. But certainly, the resources that are being devoted toward treatment, we're not seeing that as much with resources being devoted towards testing. And so you've got this great treatment tools that can't be used because the testing isn't available.
Or worse, they may be used and used inappropriately. In Puerto Rico, I met with a doctor who runs a federally qualified health center in one of the southern states, I think in Mississippi. And she said to me that in the past, the priority was to get simple point of care tests to everybody. And then if there were complexities, if you had false positives or false negatives, then you would sort of go to the reference laboratory for further testing. But now she feels, in the context of long-acting antiretroviral therapy for both PrEP and treatment, that the need actually up front is to have access to the more complicated, more detailed laboratory tests with, high throughput and greater sensitivity. So you can decide whether, with your patient, whether long-acting is right for them. And I suppose that was a bit of an aha moment for me. And I just wondered, how you both reflected on that. Tamar, I don't know what you think.
It's very important that we pay attention, and very close attention, what testing we are using, especially when we have now this PrEP era, and people are getting, whether on oral PrEP or cabotegravir, which is the long acting, and we will see that more PrEP choices will be on the market soon, and that's really delightful. But at the same time, we should not forget that the testing is key, and what kind of testing you do. Because, for example, if you do the testing, like you mentioned, the point of care, and the person is on PrEP, and then, for example, long-acting PrEP, and this person gets HIV, you may not diagnose this person early enough, and you may be putting this person actually at risk to have the resistance towards the first regimen drugs, and that will be the case, for example, for cabotegravir. So it's extremely important that we are aware, what testing algorithm tells us, and really go with the recommendation. And this is the advanced testing, which we call PCR. So it's absolutely critical that when per person is on PrEP, they do both immunoassay as well as the advanced testing, not just to ensure that this person did not catch the HIV.
And I wanted to get onto the question about for who PrEP should be available. And I know this is something, Ben, in preparing for the podcast, you and I were giving some significant conversation to. I'm thinking of another presentation I saw in Puerto Rico where a physician from Missouri this time expressed the view that she felt that PrEP should be available to anyone who has sex. Therefore, diagnostics to confirm that they're not HIV positive before they start PrEP. And she said, that's everybody. It includes my mother, who lives in a retirement community in Florida. And she went there. She raised the issue with her mum. There are lots of very friendly gentlemen who are fond of the company of ladies, she said, in the retirement community. So she talked about PrEP and HIV testing with her mum. Her mum wouldn't talk to her for 6 weeks afterwards, but nonetheless, it was an important thing to do. So, Ben, US, I suppose, guesstimates say that around 1.2 million people should have access to PrEP. But how accurate is that figure? How was it reached? And what should we really be thinking about?
I'm so glad you asked that question, because if you look anywhere in the literature, and I heard this number 4 or 5 times yesterday, even in the conference, it was an estimated 1.2 million people in the United States could benefit from being on PrEP. And that number just seemed, I was just curious where that number came from. It seemed a little bit low. Like 1.2 million can benefit from PrEP, eh? And I was like, well, there's 1.3 million incarcerated men right now. There's perhaps, I think it was about up to about 5% of the US male adult population who might identify as either being only or predominantly attracted to men. There's about 30%, depending who you ask, of women may engage in anal sex. There's a real, I feel like our messaging is really, we've almost gone back to like, this is a gay disease. If you look at a lot of the ads for PrEP, it's heavily focused, like, male couples. And an interesting article just came out in Medscape entitled, "Are you putting your female patients at risk by not talking to them about anal sex?" And I asked a number of colleagues if their primary care providers had these kinds of conversations with them. Most of them said their primary care providers hadn't even talked to them about their sex lives at all. But I went back to that 1.2 million number, and it comes from, as far as I think, its earliest appearance in the literature is from a 2015 study that was posted by the CDC. And I think some of the key takeaways from that are that 1.2 million was arrived at going, well, an estimated 1 in 4 sexually active adult, HIV negative adult men who have sex with men. So they were saying, of the men who have sex with men in the US, 1 in 4 could benefit from PrEP. And I'm not sure that I agree with that, especially in the context of, like condom use. I actually saw a terrifying statistic recently that said that condomless sex among male encounters in the US has actually decreased from about 50%. Has increased from about 50% to about 70%, 72%. So approximately 72% of MSM encounters are unprotected. And perhaps it's not surprising that things like chlamydia and gonorrhea and other STIs have really been on the rise. I mean, that should be a real red flag to us in terms of the risk, and perhaps that the number of people at risk, should really be updated. I just did back of the envelope calculations going, all right, there's this many incarcerated men, there's approximately this many sexually active men who have sex with men in the United States, this many who are having condomless sex, this many heterosexual, among heterosexual couples, condom use, depending who you ask, is around 50%. And, we really have to look at this. We've talked about at-risk groups, right? We're going to focus on this group. And not only is that a bit stigmatizing, I think it's also fundamentally the wrong approach. Yes, if you belong to a certain group, you are probably statistically more likely to be engaging in certain behaviors that are riskier. If you're an IV drug user, you're certainly statistically more likely to engage in sharing needles than someone who doesn't use IV drugs. But if you have an IV drug user who's celibate and doesn't share needles, they're at less risk than a heterosexual woman who has a casual encounter and doesn't wear a condom. So, when I looked at this I think it would be more like, it's not 1.2 million, some back of the envelope calculations put that at probably more like 10 or 12 million at least. Because if you're having sex, and it's especially unprotected sex, you're at risk. End of story. And focusing on the behaviors that put you at risk, not belonging to a group, but engaging in behaviors, I think might be a more appropriate messaging, than saying like, this is for gay men. Well, no, this is for anyone who's engaging in unprotected, either vaginal or anal intercourse. Right.
Now, it reminds me, and I would be remiss in not saying this, but observations and review of evidence by the European Britain-based advocate and policymaker Gus Cairns, who noted that for people who are in the continuum of prevention and care, the appearance of sexually transmitted diseases in a world of U equals U and regular diagnostic testing for prevention and use of PrEP, those rates go down. But that's because they're aware and have the information. It's where people are not connected to the continuum that you start to get the problem. And I guess, Tamar, from the health policy perspective, the order of magnitude of PrEP availability that Ben is referring to, how realistic, how possible is that from a public health and policy perspective?
First of all, thank you both, Bens, for the first question that Ben Plumley asked to Ben LaBrot, so since you both, Ben, because this is it's really puzzling, how this is possible that we even thought that it's only 1.2 million, right? So I don't know where this number coming from, but definitely it's a lot more. In terms of the answering your question, Ben, yes, absolutely, it's possible. Everything is possible when you have the political will and you put your mind into it and really do the right communication and the messaging, whether that you need to update the policies or implement, certain things. However, I could see the challenges as well. And it really, comes back to the, are we ready in terms of the infrastructure and what, bandwidth we have? How much time, for example, we can allot to the patients because, the doctors need to get involved in terms of, allotting, more time to the patients. And we know that right now it's really 10 minutes or 15 minutes, but we need to ensure that this is really, more. And every patient is asked, for example, the sexual history. And we should not ask, are you at risk? Because I don't even think this is positive question. What do you mean, right? So you should probably be more open and hearing from the patient what kind of behavior, like Ben said before, this patient is, or even without asking any behavior, just telling about the PrEP and HIV, etc. Right? Just a simple example is that, like we said already, that it's forgotten disease, and a lot of the young population that I've been asking around, they don't even know what the HIV really is because they I think it doesn't really exist, or it exists, but it's not a big deal. So this should be, really emphasized. So coming back to the, question, Ben, I think, yes, it is possible. We need to make sure that we clear barriers to access the testing. And it should be all about also health equity, making sure that providers are aware of the updating algorithms and then, pull into the broader population for sure. Also, we need to help the healthcare professionals understand how and when, they need to be testing in general and in relations to PrEP also, how to talk with the patients. We also need to do the more partnerships with communities because communities are the primary voice. They are the ones that we need to engage. They should be our primary partners. So I think it's possible, of course. I think it's definitely. It's only, we saw the COVID example also. We did things in a matter of months, or when even vaccines, right? It's for in my mind it was impossible because I knew that to develop any vaccine it takes years. But yet, when everybody's mobilized, when there is a will. When there is a panic, which is not a good thing, but that's the reality. It made it possible. So,
yeah. And how do you maintain a sense of emergency over the long term? It goes to the heart of the difficulties of human behavior. But just one other policy question before we move on. You at AIDS 2022, I think we were all looking for proof points to show that HIV testing was incorporated into the overall care continuum, the overall interactions that people have with health facilities. And there was one presentation in particular that had highlighted that, I guess, possibly for cost saving or possibly because the sense was that HIV is no longer the public health challenge that it used to be, that routine HIV tests are not being offered in the emergency room setting. And I just wondered what your thoughts were on that. Ben, could I start with you? I mean, how much sense does that really make?
I mean, on the one hand, it makes a lot of sense because you can imagine what kind of bandwidth, emergency room doctors or even primary care physicians have for, all of this extra stuff, right? On the other hand, it's really frustrating, because especially for many populations that are hardly reached, their most common intersection with the healthcare world is through the ER, often using it as their primary care. And you hate to see, it's frustrating if there's an issue that requires a solution for which a solution doesn't exist. Yeah, but it's much more frustrating when there are opportunities that are missed. And I always feel like not doing that kind of screening in the ER and the paper that we're referring to was a really interesting paper at AIDS 2022, where they went back and looked at all these emergency room records, people presenting for broken wrist, everything. And they went, looking back at this now, this person probably should have been offered a test, this person, this person, this person. And they went back and saw what percent of those people later turned up in the healthcare system with HIV. And it was a significant percentage, that was a missed opportunity to connect them to care. And, it's a lot like, imagine that you spend a lot of time organizing beach cleanups and putting trash cans on the beach and putting up posters showing where to fit. And then you made it really, you put a lot of tools in place so that people wouldn't litter on the beach. And then you watch someone else walk right past a piece of trash on the ground on their way to the trash can and not pick it up and bring it with them. It was sort of that kind of feeling of like, you're so close. The opportunity was there without that much extra effort. And that's what was, it's so hard, to actually get enough testing out, especially to certain patient groups. So when you had an opportunity like that that's missed, it's just frustrating.
And I guess that very neatly gets us into the question of the role of the broader healthcare professional community in offering HIV testing, and increasingly they are going to be called upon to provide PrEP, and just what we have to do around educating and giving them some experience of knowing what to do with PrEP. We're going to be relying, if we're going to look at this kind of order of magnitude increase in the availability of PrEP, we're going to be looking at nurse practitioners, primary healthcare physicians playing a much greater role. And Tamar, I wondered what your thoughts are about how in the United States we go around mobilizing and educating and preparing our public health our healthcare frontline healthcare professionals for this new massive rollout of PrEP.
I would first, what comes to my mind is education, and this is and the second, what comes right away is like it's everybody's responsibility, and we as an industry also, we're heavily already engaged into the education as much as we can, but we need to get our messaging and the word out. All of the stakeholders, and that also includes the medical associations, even medical schools. We need to also teach medical students and the fellows about the testing, why this testing, for example, and all this strategies, how to approach the patients in terms of the primary care physicians. And you said it right during, we actually mentioned it during the conversation that now that PrEP will be offered not only by ID physicians, luckily, but and I'm really delighted about this, but also like primary care physicians, the nurse practitioners, even pharmacists. This is incredible, but are they ready? No, because it's complicated algorithm. We mentioned it. It's complicated even for the ID physicians, and Ben brought the example. And ID doctors also need to get heavily involved to educate the primary care physician, because they are the ones who have seen these patients. They are the ones who have the data in front of them, and they can easily explain, easier, I would say, not maybe easier than maybe other, some other stakeholders. But education will be my main probably targets, and for all of the stakeholders. So we all are prepared, and we all know what the importance, the approach, and how we can make it also sustainable to reach the goal.
And I'm sort of reflecting on a comment you made earlier, Tamar, about at-risk behaviors, and asking people, so are you at risk of HIV? I mean, the answer is going to be no, isn't it? And that brings us to both how we educate and prepare our frontline healthcare professionals, but also how we think about the populations that we need to be reaching out to. Ben, to your point earlier about hardly reached communities, and I have to say that came to me. I got chided by a physician who is based in Chicago. She's a clinical psychologist, but she's also part of the San Francisco Community Health Center that I'm the chair of. And she told me off for using the word hard to reach populations. She said, no, Ben, these are hardly reached populations. The issue is not that they have found themselves to be disconnected from care. It's that the healthcare facilities, the healthcare authorities themselves haven't adequately found ways to engage them appropriately. So I hear you picking up on hardly reached populations, and I just wonder why that shift resonates with you.
I think because I spent so much time working with quite literally hardly reached populations who were isolated by geography, on the other side of a jungle-covered mountain, and where there's that great expression, if Muhammad could not come to the mountain must come to Muhammad, right? We like to really kind of try and put as much personal responsibility on being able to participate in care onto patients. Like, that's empowering for patients. But often that actually really starts with, or it should start with, the health system and other stakeholders reaching out and helping connect that patient to care, because many patients who are hardly reached face unbelievable barriers to accessing care. And for those patients, it probably should be the primary responsibility, not of the patient, but of the healthcare system, to reach out and help them overcome those barriers, especially if it's the healthcare system that is saying, we are going to end the epidemic. If we're taking the responsibility of ending the epidemic, that means that we really have a responsibility to help connect these hardly reached patients to care. Going back to the example of, like nursing homes, there's often this kind of ageist assumption that no sexual activity occurs after a certain age. And people who have worked in, elderly populations know that that's really not the case. And that there is a lot more sexual activity among like elderly populations than one would imagine. And, we ignore that population because of certain ageist assumptions, it really is the responsibility of the healthcare world to be the one reaching out, especially to patients who really have significant barriers, or knowledge gaps because they've been ignored, for so long.
I mean, it's right across the board, isn't it? It's back to this question of people who have sex, and that forces us to have some very difficult conversations. I was struck by some of the recent articles that the journalist Ben Ryan has been writing for the New York Times and for others, including a very vigorous set of conversations on Twitter about focusing not so much on at-risk populations, but being really direct about at-risk behaviors. And he was thinking particularly about monkeypox. And while it's absolutely the case that the majority, the very large majority of cases in the industrialized world are in men who have sex with men, he came down to the fact that it's very specific behaviors, and that we needed to be talking about those. And so there might well be young heterosexual couples who also needed to be aware of monkeypox and avail themselves of the vaccine. And again, I think, Tamar, it comes down to what the policy approach has to be. I mean, how do we get information about what is essentially very private and sensitive behaviors in whatever age we are? How do we get that across in a way that enables people to make changes to their behavior?
This is the great question, Ben. I will go back and say that we need to stop looking at the groups. This is like, in my mind also, it's wrong. It's the behavior that sometimes, puts you at risk, right? And that you may have it once in your lifetime. You may have it many times in your lifetime, but it does not make you in certain groups, right? And to come back also to another issue, the monkeypox can be transmitted in another ways as well. And we all know that it's not sexually transmitted disease only. But most important is the communication to the public. And most important is the perception. We know that, we may perceive something and then it's like in our head and, nothing you can do about it. So, and we witnessed it also during the COVID, how the communication affected people's mindset and how dangerous that could be, if it's the wrong messaging, especially from either it's from the leadership or leadership in the public health or from healthcare providers. All right. So we need to be really careful what kind of wordings we use, how we group people. Do we even need to group people? Let's talk about the disease. Let's explain this to the public that this is transmitted by this, and this ways, and be careful without saying that this is certain people groups disease and they need to be mindful. So that's key for me, is the communication and the messaging, and really everybody should be aware as much as possible. If there is a danger in the community, it's everybody's problem. So we need to just make sure that the people are aware of this danger equally.
So one last question. There's sort of no getting away from this. Although I really don't want this to become a theological or metaphysical conversation. Recently, of course, there was a ruling in Texas that allowed employers not to provide PrEP in services, particularly in the Affordable Care Act, as it mandates, as it violates, religious freedom, and that there might be employers for whom, sexual behavior between men who have sex with men, sexual behavior that involves anal sex, period, that this might be something that they have religious opposition to. And not to get into the details of the ruling itself, but more about how you both feel that practitioners, experts like yourselves, can really engage with policymakers to make sure, as far as possible, that decisions are rooted in evidence, and perhaps not in pre-thought through prejudices or values that perhaps, while important, don't necessarily root themselves in public health behavior for a broader community. Wow, I was doing my best there, Tamar, to be British and diplomatic. I don't know if I achieved that or not, but wow, what a mealy-mouthed way of saying it. What do you think?
From the public, it comes down to what we see and what's happening also in other places, because we kind of want everybody to be treated equally, right? If one state goes with another ruling, it's kind of dangerous from the public health perspective, because we are talking about the people also in that state that may need another messaging. Not me. I'm sure I want also to go as diplomatic as possible, but it's just from the public health perspective, it's really dangerous, because we want to eradicate HIV transmission. And the only way we can do that is just to do three things. One is to test people to identify that they are HIV infected, link them to the care if they are positive, treatment, and link them to PrEP services if patient needs, and if we believe also to advise, patient that there are such choices on the market. So that's the only way we can achieve this. So I think from public health perspective, we need to be really mindful how we approach some of the things.
And Ben, sort of final word to you on this. I mean, floating doctors, as well as providing the services that communities and relief agencies ask you to provide, you've had to negotiate with authorities. And again, coming back to this example in Panama, where the authorities approached you to support them in providing PrEP to indigenous communities. How do you go about having those conversations?
You mean with the Ministry of Health or patients, or both?
With the Ministry of Health at the policy level.
Oh, sure. So this is where the relationship that end operators have with the patients, can provide real value to ministries, because we will probably go about this by having lots of long conversations. And this is where I'm a little bit spoiled. We don't have 15-minute consult limits, so it could be quite common that a consult could last for an hour, which really gives us a lot of time. It might be in someone's home as well. So it really creates a lot of opportunity for, not only transmitting information, but gathering information, that's very important to then merge with, the same information we're gathering from other patients to get a real sense of like, well, what are the real specific barriers and opportunities here, and communicating those. So we will be able to really, kind of provide to the Ministry of Health, okay, so we think that these are the solutions for PrEP that are going to work well. Like these communities, I think the oral PrEP is going to be more ideal. These communities, possibly the injection. We're going to be able to provide more micro level, kind of feedback, that the Ministry of Health may not have access to, because they're just not sitting down with these patients day after day, for an hour at a time in these very remote settings. And I think this is a similar situation where, the physicians in the U.S. generally don't have a particularly strong voice in the creation of policy. And I think I have a particular perspective on this because, of course, I trained in Ireland and I was a member of a medical union. And I will never forget, as an intern, our employer, the government, I think said something like, guys, we're going to have you do, I think it was like 4 nights of call every week plus post call. And our union essentially went, we'll walk out tomorrow. And the government, all right, 2 nights of call. And I remember having this aha moment going, oh, so this is what it's like when physicians actually have a strong policy voice where they can really impact policy. And, I think physicians in the US, many physicians for a long time have really focused on taking care of patients, and they've left a lot of policy decisions to non-physicians. And this is often where you get this disconnect. So in the case in Texas, I think this is a really good example of where physicians, healthcare workers, infectious disease docs, and society can really, this is where they can leverage their knowledge and convert that knowledge that they have into a voice, that can really advocate. This is not just about providing treatment, now. This is now about advocacy, about bringing information that's in the heads of these doctors out into the public discourse, and making sure that policymakers, have that information, so that they can make policy decisions that align with, the real world current landscape.
Well, I realize that we are well past the top of the hour, and you have indulged me very, very graciously in getting into more detail about the opportunities and challenges of the role of diagnostics in this new era of HIV management. But sort of stepping out of this a bit, just to wrap up, again, how are you keeping sane? What have you been binge watching or reading or doing? Tamar, what's your escape route at the moment?
Actually, for me, it's more like, again, it's what keeps me sane is to have the hope. And I hope about that. Like we can do so many things. And I said it also the previous time, and I remember that conversation. But now I see that, we are getting united more and more globally. And that's really gives me the hope. That means that to me, that we kind of get into the realization even more that the health is the human right, and we are all equally entitled to access the services. And I really, really hope that during my lifetime, I will witness this, and I will witness also the paradigm change, which again means that we will not be thinking about, health is not really given to me. I need to fight for it. So that's what keeps me the same these days.
Thank you. And Ben, what is inspiring you?
It's funny. I didn't know what Tamar was going to say, and it's so similar. Especially in the work that I've done, I feel like I've had a ringside seat to some pretty awful things that humans can do to each other. And alongside that, though, I keep encountering men and women who are usually toiling in complete obscurity, who really refuse to give up the notion that the world is a fine place and worth fighting for, and do so. And they just never give up expressing their skills and talents in a way that is compassionate, and of service. And when you meet these people, once they're no longer in your vision, you still know that they're out there. And knowing that they're out there, always gives me so much hope. And seeing what the world is capable of when it does come together. The number of people reaching out across borders, across barriers, really, it's encouraging. It's a struggle, but I think we're all in this together. We're not alone. And of course, what keeps you sane presupposes that I am sane.
Well, yeah, I'm just assuming
that my wife, she might say.
I'm assuming that you are. And it really strikes me that healthcare professionals, physicians like yourselves, you really are a beacon of hope in this difficult time. So, Tamar, Ben, thank you both very much. As we said last time, you are both shots in the arm.
Thank you, Ben. Absolutely. Delightful conversation, maybe a little bit sad, in many areas that we touched. It's pain points for all three of us, I know, but it's good to be out there with you, especially, and have these honest conversations.
Yeah, I thank you again so much for having us on. And a constant series of crises, but a constant series of opportunities, and a lot of people who, like that ID doctor who was like, it's totally impossible, but I'm going to do it anyway.
Yeah,
totally impossible, but I'm definitely doing it. Yeah. And as long as that attitude is out there, we'll get there.
Well, that's it for this episode. Thank you to Tamar and to Ben, and thank you to Roche Diagnostics for sponsoring the episode. Thanks also to our director, Erica Spera of NewsDoc Media. And finally, a big thanks to you. You can find us on all podcast platforms, subscribe and give us 5 stars, and check out our YouTube channel. Hit those like and subscribe buttons to help us spread the word. Have a great week and a safe week, everyone.